Hi, this is Stephanie Sena. Welcome to our new radio show called Thinking Constellationally, where we connect the dots among systems of inequity and between ourselves and our neighbors. So today I have a very special guest on the show, Dylan Toolajian. Oh, really?
That was good. It was a great start.
Dylan Toolajian.
That's it.
Okay. And Dylan was a nurse at Hahnemann Hospital, and he was also a board member at large of the Hahnemann Hospital Nurses Union. So today I wanted to spend some time talking about healthcare and its connection to poverty and income inequality, and also social determinants of health. I believe that the closing of Hahnemann Hospital disproportionately affects people who are living below the poverty line in Philadelphia. So I invited Dylan to speak a little bit about that, and he was an advocate for keeping it open. And sadly, we lost that battle, and it is shuttered. But Dylan is brilliant and passionate about what he does, and an expert on the topic. So I'm so excited to have you here today, Dylan.
Thank you so much for having me. It's a pleasure to be here.
So, Dylan, let's start by if you could explain a little bit about how we know each other.
We met a long time ago in the 1930s. No, not completely. Back when I was a student, when I was in college studying nursing, I took one of your courses, History of Homelessness, which really opened my eyes to ways I can involve activism and advocacy in my daily life. And it was really an important time for me because my education, my formal education, had been all clinical up until that point. And your course really inspired me to examine some of the sociopolitical aspects of caring for people outside of the scientific piece of clinical nursing, which was really amazing. And then having met you, I then started to volunteer at Sri Hup at the Student-Run Emergency Housing Unit of Philadelphia, which was a really amazing experience in which I miss right now while we're in our transitioning phase. But getting to work with some of the men who were our guests and being able to really delve into the aspects of day-to-day living, experiencing homelessness, that was really incredible. And it's just been a total honor to witness sort of your journey in making that organization flourish the way that it has. And I'm so excited to continue working with them. It's really amazing.
Wow. Well, thank you so much, Dylan.
Yeah.
I feel the same way, is that it's an honor to get to watch you really flourish in your role and go from being a student to an educator yourself and someone who advocates tirelessly for people who are vulnerable and on the edge. And so I've watched you do that over time, and you continue to make me proud. So,
Thank you.
And you've taught me so much from the way that this system works to the issues that you encounter as a nurse in Hahnemann Hospital to how to bake bread.
Yes.
So,
chief among my skills.
Yeah. Which we'll talk about maybe later as it pertains to self-care, which is something I kind of also want to cover today, because when you are caring for other people, as many of you listening probably are, and as Dylan and I certainly are, it's so important to learn how to care for yourself so that you don't burn out and you can continue to do this advocacy work. Mm-hmm. And so Dylan has taught me a lot about self-care and how to keep going. And on a day like today, where I kind of woke up and felt like this is just all too much, and I want to quit and maybe move somewhere far away. Dylan is fantasizing about maybe joining the circus.
Yeah.
So do you know, like, what capacity in the circus?
No, I feel like I would probably have to sell tickets or popcorn. I don't really have any
any other
amazing skills.
Okay. So Dylan's going to join the circus to sell tickets.
Yeah, strictly for sales.
Okay. And I don't know. I'm not that creative this early in the morning before my coffee, but something else other than this. It's just some days can be completely overwhelming, and so at some point in this show today, we will spend some time talking about self-care. But let's dive in, Dylan. So you have so much experience, and you've been on the front line of this fight to keep Hahnemann open. Mm-hmm. Can you kind of give us a little background for listeners who maybe don't know about what was involved there.
Sure. So Hahnemann University Hospital, it just closed officially in the beginning of September. It has been open in some capacity since 1848. So over 170 years, since before the Civil War, which is really crazy to think about. And has been a teaching facility and a tertiary care facility in Center City, Philadelphia for a very long time. And traditionally, Hahnemann really served the populations of Philadelphians who have a hard time seeking service elsewhere, specifically local people, specifically people of color, specifically immigrants, the underinsured and uninsured. So that has just sort of been the trend. As long as Hahnemann has been a functioning facility, it has really brought in a crowd of patients who have a lot of challenges, often multiple intersecting challenges, in seeking their healthcare services elsewhere. It has really been a hospital for the people, and that's why it's so heart-wrenching that it's closed. As far as I can tell, Hahnemann has struggled financially for a really long time. It hasn't been in the black in many, many, many years, like almost 100 years.
Do you know why that is?
It has changed hands many times and has faced competition from the other health systems in the area, especially in the last 60 years, really, with the consolidation at the University of Pennsylvania and with Thomas Jefferson University. There are some big players in Philly, and Hahnemann has never had enough beds to branch out and create more buildings and require more space. So that's sort of the circuit as relates to Philadelphia. But additionally, the way that our for-profit healthcare system works does not put any facility at an advantage that cares for anybody who is not paying top dollar for their healthcare. So that is everybody that I just described, the underinsured and the uninsured, immigrants, people of color, people with no preventive healthcare services, people with no wraparound services. If those are the patients that Hahnemann sees, and those are the patients whose services earn less reimbursement for the facility, then it's not a surprise the facility makes less money and it struggles financially. So everywhere in the country, not just in Philadelphia, we see hospitals that care for these underprivileged populations struggle to make ends meet a little bit more, and that's because we don't reimburse those hospitals as highly for those services. When you are a patient who's receiving healthcare with Medicaid or Medicare, the treatments that you get as the patient are the same at the facility, but the facility earns less on reimbursement than through a private insurer. So if you have private insurance, you have a private payer, that private insurance company might pay more for a joint replacement than Medicare might pay. And so hospitals have become accustomed to being selective when they can about how many patients they can provide charity care to, quote unquote, because the limit that they can earn back on those services is very real, and they have to be cautious about how much they spend.
When you say they make these selections, can you talk a little bit about that in terms of how do they make these selections?
Sure. So hospitals can't really refuse care. Public hospitals certainly can't.
Was Hahnemann, I'm sorry, public or private?
Hahnemann was a private hospital.
Okay.
It's interesting that you ask, actually. Philly is the sixth largest city in the country, and it's the largest city in the country that does not have any public hospitals.
Wow.
Mm-hmm. So Hahnemann,
I think that's probably part of the problem.
Totally.
Absolutely.
Hahnemann was the closest thing that most Philadelphians would consider to be a public hospital because our doors were open all the time, as all hospitals are, but we were really seen as being the place to go if you couldn't go anywhere else.
Okay. Wow.
So public hospitals definitely can't refuse care. And if you go to an emergency room, you will receive care, regardless of whether or not you're insured, regardless of whether or not you can pay. There are federal laws that protect the patient's right to be cared for in an emergency.
Is that true in any hospital?
That's correct, in the U.S.
Okay.
And there are processes for if you go to a small hospital and you're having a significant emergency and that hospital doesn't have the technology to take care of you, there are laws that describe the way in which your doctors have to stabilize you so that you're safe and move you as soon as possible to a hospital that can provide your care.
Okay.
And so there are lots of laws that protect the patient's need to be seen and immediately cared for.
Okay.
But for patients that are not able to pay for all their services, hospitals do need to have systems, all healthcare providers do need to have systems to ensure that if services are going to be rendered to the patient, that they're paid for somehow. So whether or not that ends up being charity care, whether or not we're seeking emergency aid from maybe the state or the city, whether or not the patient is fundraising for themselves, which sounds crazy, but it is something that patients
more and
do.
more.
And it is something that some hospital officials have started to recommend to patients.
Yeah.
Is
GoFundMe pages
yeah,
and
really
things.
pump your community and see if you can get some money together to pay for the surgery, which is nuts, right?
Yeah.
But
Which is something I've experienced firsthand.
of course.
I have a TED Talk about this that you attended
Yes.
in Philadelphia in May, and this past May, where I talked about comparing my experience with healthcare and somebody close to me who had been homeless and was in our shelter, Jay. And Jay, both Jay and I have had amputations. And Jay had, and both of our amputations were emergency surgeries because we were both septic and terminal. And so Jay had this surgery, and he needed his leg removed, and he was at Jefferson Hospital. He'd been in the hospital for a few days with a blood clot. He was incredibly sick. They eventually had to do this emergency operation. And then after they performed the surgery, very soon after, before he was really stabilized, they did kick him out.
Yeah.
Without any type of, treatment or any place to go, really. And there were no shelters at that time in the city that could take him. All shelters were at full capacity, and any of the beds that were available were not wheelchair accessible or accessible for him. So this was an incredible struggle, and it made me think a lot about my own amputation, which had only been I've had 5, but my last one was not quite a year ago. But I also ended up not having insurance that covered me. I bought an insurance plan that I thought was full coverage. I was deceived by the agent that it was full coverage. And actually, this plan was a plan that was illegal under the ACA, the Affordable Care Act. But the Trump administration has started to erode at some of the protections in the ACA, and one of the protections was that was there originally was outlawing these scam insurance plans that pass themselves off as full coverage when they're not. And so I didn't know that, as most consumers don't know that, and I couldn't afford a more expensive plan. So I bought this plan that was about $300 over a month, which to me was a lot of money. And I thought, as the agent had explained, that it was full coverage.
And money well spent, you would think.
Exactly. But then when I ended up getting very sick and in the hospital, the insurance refused to pay out, even though I'd been paying my premiums for months on time. And so the hospital ended up, I needed a PICC line, an IV in my arm, went to my heart where I could administer antibiotics so that I could leave the hospital after being there for a week. With sepsis, and the insurance company wouldn't cover that medicine. So I ended up needing to get charity money for that. And then I needed a partial amputation of my foot, what's called a transmetatarsal amputation, and insurance wouldn't cover that either. So I needed to depend on the community for that. So I have very real experience in seeing more and more we are depending on these systems of charity, basically, to cover it when insurance won't, and when the state won't, when the federal government won't. And as you said, and this is important, that when it comes to people who are living below the poverty line or who are uninsured or underinsured, this becomes a huge strain on our healthcare systems. And so it makes sense now that you're explaining this, that it hurt Hahnemann more so than other places, since Hahnemann was really the hub for that population of people.
Yeah, well, Hahnemann didn't have much reserve to work with. So when you are working with patients whose ability to pay for their care, especially if it's significant care, is unsure, then you as the facility assume a degree of risk for making sure that if the patient needs to receive the service, number one, that they receive it. That's the most important thing, right? We want to deliver the treatment. But also that it doesn't drive you under the ground to do so. And in the case of Hahnemann, part of the issue was that we were unable to recoup the losses from operating the facility for a long period of time. That being said, none of that burden falls on the patients, right? Because this is a service industry. It's also, healthcare is, I believe, a human right, but it is also a public good. So we have to really ask ourselves, working in this business, and it is a business, unfortunately, is there benefit to any angle of it being for profit when that translates to harms delivered to the client, which is the patient? And
also, as you mentioned, it's a public good. So if this care is not delivered, it can also have an implication on the community at large.
right.
Can you explain a little bit about that? How if a client isn't treated, or clients, plural, who are low income aren't treated, how that might have a ripple effect on other people who might not necessarily be low income?
Sure. So, do you mean when people choose not to seek services, or
No,
if they can't afford to pay?
if they can't afford it, and so therefore hospitals don't care for them.
Right. So the big thing with underprivileged populations is ease of access. So Hahnemann, as an example, was located at Broad and Vine. It's in the middle of the city. It's accessible by multiple methods of public transport. It was a level 1 trauma center with a big ER. So there are multiple angles for people to get in and be seen. They can walk in off the street. They can take a bus, a trolley. They can take a train. They can drive. There are many points of access, right? And it's a large building on a block where there's not a lot else going on, so it's visible. You can look up from multiple parts of the city and see it. So these seem like funny descriptors of the building, but they play a role in how accessible the building is to the patients who are seeking service there, right? So when we're talking about making sure that patients have the ability to get in and seek the services that they need, part of it is whether or not they can pay, and whether or not they feel fear about paying, and whether or not they can actually make it there. So when we lose a hospital like Hahnemann in the area that it's in, if you have your own car, if you have relative ease of transport, if you have a lot of time on your hands, if you work in an industry or at a job where you can afford to take time off for a doctor's appointment or something like that, it may not seem like a big deal that the hospital is not there because you could go somewhere else, right? But for somebody who maybe can't walk unassisted, or who needs an oxygen tank when they walk around, somebody who has an amputation and relies on a cane, a walker, a prosthesis, something like that, to have the nearest hospital to you be moved just a few blocks away or a few minutes away is a huge, huge issue. And a big part of preventing people from getting the services that they need.
That makes perfect sense. We're going to take a short break right now, and we're going to come back because we're going to explore how this affects everybody in the city. Thank you, Dylan.
They call me Maxie, but I prefer tripod. I was your above-average four-legged homie, and then wham-bam minivan. Some people pity me. Now that's lame. I still run, fetch, and swim. And the ladies love me. I'm the ultimate wingman. Just don't ask me to high five.
Being prepared is a part of who you are, but it's especially important in the case of a disaster. Be informed about possible emergencies in your area. Make a plan that covers where you go in an emergency. Build a kit with the things you need to survive. There's no one more capable of planning for your situation than you. Start your plan today. Go to ready.gov/myplan.
Okay, so we're back with Dylan Toolajian.
Yeah, that was perfect.
Okay. And I want to connect this issue that you're exposing to an article written by Malcolm Gladwell in 2006 in the New Yorker. It was called $1 Million Murray. And it's about why problems like homelessness may be easier to solve than to manage. So basically, there are people like you and me who consider ourselves to be activists, who really care about other human beings and people who are vulnerable and suffering, and feel some drive and compulsion to really strengthen the safety net and make sure that other people have access to the services that they need to thrive. Right. So, but not everybody operates like that or thinks like we do, Dylan. And so, those who do think like us, we're trying very hard to make the case politically for why we should care, why we should care for people who are low income or homeless or suffering on the street. If there's an attitude that it doesn't affect me, right? I can't see it. It's not my problem. They're not my people, not my issue. So in the early 2000s, some thought leaders, some researchers, some academics started to think, how do we reframe this issue to alert the public that we should care, not just because it's the humane thing to do, but also because to care for people on the margins is good for all of us, right? And so the easiest way to make that case is a financial case, is to say to care for people on the margins actually gives us an economic benefit. Right. So you have people like Malcolm Gladwell, and his article, $1 Million Murray, which I recommend, is that he talked about this man, Murray, who was homeless on the street for about a decade. And there was a calculation, I think that he was in Reno, Nevada. And there was a calculation that over the decade that he was homeless on the street, he cost the taxpayer about $1 million, which is where the title $1 Million Murray came from. And most of that was from ER visits. And so he was in and out of homeless shelters, in and out of ER stays, and this was basically, he was using the ER, as many people who are homeless have to, as basic health care and basic prevention. Not only are people who are homeless and low income more likely to get sick and need hospital intervention,
Right.
but so really illness can often cause homelessness and low income, and it can be an effect. It can be a cause or an effect of living below the poverty line. And so there's a disproportionate use of ER visits on people who are homeless and or low income. And so basically people started to quantify this and say, if we just allow people to suffer on the streets, aside from it being inhumane, it's really expensive for the rest of us because those costs are passed off on the taxpayer. And so so people started to quantify that. Another man is Dennis Colhane. And in the early 2000s, he wrote he did some research and had his writing in journals, which stated it is more cost effective for the taxpayer to put people in housing than to let them die on the streets, mostly because when those people end up in the hospital and they don't have insurance, they're uninsured or underinsured, someone is going to have to pay for that care. And in the end, it gets passed off on the taxpayer.
That's correct.
So the idea was, let's care for these people, not just because it's humane, but because it helps us all. So if we're making the case, obviously there are people who are listening who feel like, yes, it is the right thing to do to provide health care and needed services to people who are low income.
Totally.
But other people, aren't as convinced as you and I. And so there's another argument to make that when places like Hahnemann close, hospitals that provide this necessary care for people who are low income, it affects all people, not just those who are low income.
Totally.
It affects them, I think, because it puts a strain on the other hospitals. And it affects us because people who are in desperate need of health care who now don't have access to it once Hahnemann closes, that is a public health concern because it could lead to the spread of viruses and diseases that could be treated in the hospital, and if left untreated, could spread to the entire city, really. So this is an issue, the closing of Hahnemann, I think, that doesn't just affect people on the margins, but really everyone.
Totally. Well, I don't know if I mentioned this before, but about 2/3 of the patients that we saw at Hahnemann used Medicare and Medicaid. The rest might be uninsured or be using private insurance.
Okay.
And I don't mean to say that all of the patients there all the time were seeking emergent services, had nowhere else to go. You know, Hahnemann was a fully functioning hospital that would accept anybody through its ER, as every hospital must that has an ER, and would treat people of a variety of socioeconomic backgrounds, right? So having more ER visits in a single facility like Hahnemann, for example, bottles up the ER and delays care for everybody. And when you're going to the ER for an actual emergency, you go to the front of the line. I always tell people, if you have to wait in the ER, I'm sure it's frustrating, but be grateful that you're waiting and you're not the first person in, because if you're in the first person in, you're in really bad shape. So if they make you wait for a little bit, it's actually a good sign. But if you are in the ER and there are a bunch of people coming in for bruises, scrapes, the common cold, flu-like symptoms, which there are, tons of people who do that who have no primary care provider or who do not have access to urgent care or who have no insurance or an insurance plan that will not provide or pay for those things, will not pay for updated sick visits, will not pay for urgent care. Those people are going to the ER. Many of them experiencing homelessness, but not all of them. Lots of our neighbors, lots of our friends, people in our own personal circles, you and me, right? So in a single facility, that delays the ER and its ability to process patients, all patients, through the admitting floors. But when we look at it more constellationally, if you will.
I love that, Dylan.
When we look at it in the frame of reference of all of Philadelphia, all of its hospitals, when the ER is not functioning, like at Hahnemann, when the hospital's not admitting, those patients who are desperate to seek services will seek them elsewhere, if they can. Not everybody will. Some of them will fall through the cracks. They will fail to receive services, and they'll get hurt as a result, right? We're seeing that happen already. But the ones who can seek services elsewhere will, and it transfers the strain, we call it churn, in the business, quote unquote, which is patients coming in and patients going out. It transfers the churn to those other ERs, and those ERs have to process those patients too. Either they can treat them emergently and discharge them back out of the facility, or they can treat them emergently and send them up to an admitting floor. They go to the ICU, they go to a telemetry floor, they get care as an inpatient in the hospital, right? And then those patients who transition out of the hospital, they need follow-up. They might need outpatient care. So the other hospitals in Philadelphia are feeling the strain because Hahnemann is closed. And it doesn't matter what level of insurance you have or how much money you're making. If you are seeking healthcare at a hospital in the city, you are being impacted by this closure already. You may not even know it yet, but many of the hospitals in Philadelphia, the metrics that we already have for emergency wait times, many of the hospitals in Philadelphia, the wait times are already over the national average.
Wow.
Or they were before Hahnemann closed.
I didn't realize that.
Right. So now with the closure of Hahnemann's ER, which also includes what was its trauma program, which basically equates to life flights, helicopters landing and bringing in victims of car crashes and gunshots and things like that, all of that care has to be diverted elsewhere. And it's hard enough, I can tell you from being an inpatient nurse, it's hard enough to manage where those ambulances go, even when Hahnemann was open. When you're down an ER and when you're down a whole facility, all of that strain is distributed elsewhere, as it has to be. So that impacts everybody who's seeking services everywhere.
Absolutely. That's a really important point to make, Dylan. I also wanted to mention that this also affects the people who work at Hahnemann, right?
Totally.
So not just the patients. Do you have a sense of numbers in terms of how many people were displaced? And maybe can you talk a little bit about not just the staff, the doctors who were displaced, the nurses who were displaced, the orderlies who were displaced.
Absolutely.
But also, it's a teaching hospital, right?
Yes.
So can you talk a little bit about that area, not
Sure.
necessarily the patients, but the people who were depending on Hahnemann for their livelihoods and for their education?
Absolutely. So Hahnemann was affiliated with Drexel University and their School of Medicine, and it was a teaching facility, which, if you're listening and you may not be familiar, means that the attending physicians inside of the hospital use their experience and their knowledge and their interactions with patients to educate physicians who are learning. So we have residents and fellows. These are doctors who are doctors. They're licensed physicians, and they're learning additional skills in their education. They're specializing in their fields, and they are on the path to also becoming attendings and being full-fledged doctors in their own right. So teaching hospitals are like a necessary function of American healthcare, because this is how we help medical students finish medical school. And there are med students at teaching hospitals as well. But finish medical school, get their licensure as a physician, and then practice in real time and really develop the skills that it takes to be really a skilled provider or a skilled clinician. So there were lots of residents and fellows at Hahnemann, lots and lots, more than there should have been given how many beds there were at the facility. Hahnemann had about 500 beds. I want to say 496. And in the residency program, as far as I can recall, there were 574 residents and fellows who were displaced by the closure, which is the largest displacement of physicians in American history.
Oh, my goodness.
Right. So these are all doctors who are within the first couple years of their post-med school education. Some of them had just started their first residency year, July 1st. And then we're told almost immediately after, maybe 2 weeks after, that the facility would close and their residency was going to be ended and they would need to go elsewhere. Wow. So these are people who pick up their lives, move to Philadelphia, start their residency thinking, I'm finally on my way. I'm officially a physician. I'm going to get started. And then they need to be reassigned and finish their education elsewhere. Maybe they just got started. Maybe they'd been at Hahnemann for 3 years and they were starting their 4th year as a fellow and specializing in their field, and now they have to move as well. So there was major displacement of these physicians. And when you're a resident, you are most likely carrying the burden of some student debt from medical school and your school before that, your undergraduate education. And additionally, you're not making the money that attending physicians make. So to move and then pick up and move a month later is not really feasible. It wouldn't be feasible for me, and that's not even the position that I'm in, you know? Yeah. So those doctors specifically were very much disadvantaged, and they were called in the media for a time the orphaned residents of Hahnemann, because they were sort of being held in escrow almost. They couldn't really move on their own, but they couldn't work, and they were being lifted out of their program.
It's a major disadvantage, and I'm really grateful that you're bringing that up because I don't know that there was much of a focus on that in the media, and I think that there needed to be more discussion on that, and so I'm really grateful that you're highlighting these other issues, that the closing of Hahnemann has a ripple effect and affects so many people. I mean, I don't even know if we're able to put an actual number on the lives that this affects, but it's devastating, really.
Definitely. I mean, certainly. I think our ER used to see between 40 and 50,000 patients a year in the emergency department, and then a portion of those patients are admitted and get inpatient care. Some of them leave, some of them come back, So if we think overall, I mean, certainly I would estimate hundreds of thousands of people affected and in direct receipt of harm.
Yeah, these are just numbers, but you and I are so close to this that I'm thinking of individuals. I'm thinking of one woman in particular who experienced a major trauma and was pregnant and ended up the baby didn't make it, and she ended up I think her uterus ruptured, and she ended up needing major surgery and was put into a coma. And she was in the ICU for a while at Hahnemann, and she was someone that I was close with and caring for prior to this emergency. And as soon as I knew that she was going to be in the ICU in Hahnemann, I texted you and I said, Dylan, please go to the ICU and check on her and take care of her. And I knew that you did, and I knew that you would, because you offer this care to people constantly. And it wasn't just you. I know that you had a whole network network of people who were caring and loving, and she got better, and she got out of Hahnemann, and she was able to walk again, and she's doing a whole lot better than she was now. But that was an emergency crisis situation,
Absolutely.
and she was on the edge, and what we weren't sure that she was going to make it. And I think that her survival is due in large part to the care she received from you and from the other people at Hahnemann. So it's hard because these are numbers, and the numbers are important, but for each of these numbers there's a story, and there's a human being behind it.
A life, maybe more than one.
Exactly. Yeah. And so I think that these stories are powerful and important.
Absolutely.
So I'm grateful that you're bringing this up. So you also, as I mentioned in the beginning, were on the union, the nurses union, as a board member at large.
Yes.
Can you talk a little bit about that?
We had a chapter of the Pennsylvania Association of Staff Nurses and Allied Professionals, or PASNAP for short. At Hahnemann, I was a board member at large of our executive board. So we had president, a vice president, and some other officers, all of whom report to the union staff at the state level. And I'm very proud to be a union man. I'm still a union nurse today at my other places of employment.
And where are you employed now, Dylan?
I work at Temple University Hospital in the city. I work in the outpatient oncology area, which is really wonderful, which is also a PASNAP hospital, which I'm really appreciative for. And the union was really a way that nurses were able to advocate for themselves. When we closed, you asked about numbers before. When we closed, we lost about 2,500 union jobs. Wow. So those are our PASNAP nurses, I believe about 800 of whom worked at Hahnemann. And then there are some other unions involved at Hahnemann as well. 1199C was there with some ancillary staff members. So we're talking about radiology technicians, patient care technicians, dietary technicians, transporters, laboratory, laundry, environmental housekeeping. I mean, you name it. Mechanical services, everybody. So it was really a devastating blow to really labor, organized labor in Philadelphia as well, because all of these union employees, all these union jobs were suddenly up in smoke, which is really crazy. But, nurses, we tried really hard to incorporate advocacy into our practice for patients, and sometimes we struggle to advocate for ourselves. And I think the union practice there was so important because it gave us a little bit of power, a little bit of influence, and some security and some unity that was necessary in making sure that we could take care of each other and really advocate for the things we needed. Because when the nurses and the physicians and all the hospital staff get what they need, those better outcomes translate to the patients. And that's really what we all want, is better patient care.
That makes perfect sense and is such an important point. We're about to come up on our second break, so we're going to pause for a little bit, and then when we return, I would like to talk a little bit more about your role in the union as it pertained to the hospital closing, and a little bit of your advocacy there, what you saw in the last days, what Hahnemann is doing now, and how we can all advocate for better outcomes for people who are low income. Thank you so much. We'll be right back. Awesome.
Not completing high school is more of a social thing than it was an academic thing. Even though all these years have passed, I still had that longing to have my diploma. I have a mentor, and she convinced me to continue my education.
No one receives a diploma alone.
If you're even considering getting your high school diploma, go get it. You can do it.
Find free adult education classes near you at finishyourdiploma.org.
Because of you, I feel not alone in this world. And you let me know that it only takes one person to make you feel wanted.
(150/90).
180/111.
160/110. I had a stroke.
This is what high blood pressure looks like. You might not feel its symptoms, but the results from a stroke are far from invisible or silent. If you've come off your treatment plan, get back on it or talk with your doctor to create an exercise, diet, and medication plan that works for you. Go to loweryourhbp.org.
If I would have followed a treatment plan, I would not be in this situation.
So we're back for our final segment, and I just have to pause for a second to say that you are so brilliant, and I'm so proud of you. It's just
Thank
such an
you.
incredibly rewarding experience to go from teacher and educator to student. And so I love that this
Oh my
is a role
gosh.
reversal for us, because I and it makes me feel so good, because the course where you were my student was so intensive, and we covered so many really important topics, and to see you putting those topics into action, and not only that, but also, you know, teaching me so much is just an incredible moment of pride and kind of ecstasy when the teacher gets to be the student.
Thank you so much. I learned from the best.
Well, anyway, you're incredible. So I wanted to spend maybe a bit of time talking about like the end of Hahnemann, what is next for Hahnemann, what is next for you, and how we can move forward. So because it can seem that this is all a mess, right?
Yeah.
We know that this is all incredibly overwhelming, and when we hear about so much devastation in our community and the fraying of the safety net, and I do believe that the closing of Hahnemann absolutely frays our already frail safety net and
Absolutely.
makes it harder for people who are already living on the edge. And sometimes when we're inundated with that information, it's easy to become completely overwhelmed and tune out, to feel like there's nothing I can do to make a difference. And so we have to also be really careful that we measure that and we balance it with the positive, and that includes self-care, but also paying attention to solutions and to looking at other cities and other examples of how we can do better, and using other cities and learning from them from their best practices to potentially put in practice here in our region. And so I do want to spend some time talking about an interesting endeavor and an initiative coming out of the University of Illinois with its unconventional treatment for people who are homeless and considered to be super user patients of emergency rooms. So that's where we're going in our final segment, but maybe start with talking a little bit about the final days of Hahnemann and really what is on the horizon for what's happening to Hahnemann today.
Sure. The final days were pretty bleak. We got the word on the inside that the facility was going to close. As we started to discuss earlier, Hahnemann was never very financially stable, and it was purchased from its previous owner in January of 2018 by a firm from out in California. And we were told that the new owners, American Academic Health System, were interested in sort of rehabbing our picture, funneling some money into the facility in our sister hospital, which is St. Christopher's Hospital for Children, which is still open, thankfully. That they were going to funnel some money into the system and really improve outcomes for patients, improve staff satisfaction. Ultimately, none of that came to pass. And it's a really interesting and kind of a scary trend in remodeling businesses in America lately, this concept of private equity coming in and liquidizing assets. So when Hahnemann closed, we were told there was not enough money to compensate for the losses, the monthly losses of operations, and that the system would file for Chapter 11 bankruptcy, which is the form of bankruptcy that allows you to reconsolidate your assets and sort of restructure your business. So when we were told that, my understanding was that this was done in an effort to protect St. Chris, make sure that the Children's Hospital remains open and viable for as long as possible, and to allow it to continue to function, and that Hahnemann would no longer exist in its current capacity. But when I speak of private equity, this is a strategy, and it's usually done in retail, a strategy that's done sometimes by developers that allows them to purchase a business and basically destroy it and salvage the land and sell it for profit in a desirable location. This is not something that typically happens at hospitals. But I think Hahnemann's closure is a signal of this new trend, or a possible new trend. The possibility of being able to dismantle a healthcare facility and then use the property it sits on for its value, because the building where Hahnemann is, the block that it's on, is very valuable in the middle of Center City. And what's going on now, to my knowledge, is that when the hospital was purchased in 2018, the buildings themselves were separated from the land, the real estate, which had never been done in previous sales. Now the buildings are no longer in use. They've all been shuttered, to my knowledge at least. And the only people that are still there are security and the few people who are literally breaking down the rooms, getting the furniture out, things like that. And the land is extremely valuable and seemingly up for grabs. So American Academic stands to make a significant profit on selling this land to some developer who wants to turn it into hotels, condos, anything else that would make some money on that block.
This is really gentrification, isn't it?
This is really gentrification.
Wow.
And specifically neighborhoods that are already gentrifying are particularly vulnerable, right? Because the value of that land goes up. And if you can find a property that's struggling, like Hahnemann was, and you can dismantle it, you can use that space for something that will do better, that you can charge more for. And given that Broad and Vine is right by the convention center, a hotel there would make a killing. Apartments would make a killing, you know? So if you're not maybe invested in the health outcomes of the people who seek services at that hospital, you might not care that dismantling it was going to destroy their lives. Not when you can make a couple $1 million off of it.
So the winners are going to continue to win, and the losers are going to continue to lose.
Absolutely.
But in the end, everyone will lose, because this is a snake eating its own tail. Because those people who are already profiting off of this system, which is so broken, they eventually when all the other people are struggling, those problems will come to their door.
Right. It's the world's biggest pyramid scheme.
Exactly. 100%, Dylan.
The point is really, really high up there, but it's all going to get up there eventually.
Absolutely.
The biggest thing I can say about this is that the healthcare system is broken because it doesn't deliver healthcare to those who need it 100% of the time, which is really the point, right?
That's right.
But the system of power, the system of inequities in power, works perfectly. It works the way it's designed.
Yes, 100%.
This is a diffusion of power in a loop, and it's a loop that closes itself.
That's exactly right,
We
Dylan.
need to smash it open. There isn't a way to make this work for us. We just have to dismantle it.
And how do we do that, Dylan?
We get rid of everyone and we start our own country.
I love it. Or can we also do that while joining the circus to sell tickets and popcorn?
Definitely, absolutely.
Okay, all right. We're gonna. But I need a nap first.
Yes, fully.
Okay.
We'll dismantle capitalism this afternoon.
Okay, great.
For sure.
Amazing. Okay, I love this.
Yeah, in all aspects of our lives, we need to be mindful of the way that power flows, where someone seeks to make a profit, where someone stands to consolidate their own power. That is where some shady stuff is going on, most likely.
100%. And we need to be paying close attention to this.
And nobody needs to be making billions of dollars off of a hospital.
No. Nobody needs to be making $1 billion, full stop.
Yes.
But certainly not off of other people's suffering.
Of course.
And we need to cancel billionaires. Canceled.
This is the only part of cancel culture I stand for.
Okay,
Canceling
I love it.
billionaires.
I love it. But this is we're seeing like really the effects that we're feeling from this system of inequity, and the problems are being laid at our feet more and more. And so I don't think we can ignore people's suffering. But in the meantime, you and I, again, we're so involved in this and so close to it, and it can be incredibly overwhelming. So what can we do to care for ourselves so that we can continue to fight this really vital fight?
I think it's really important to take time when you can to disconnect from the things that are in front of you and around you. I think, especially when you're working in an area or working on a topic that feels really high stakes. For me, that's my actual job, right, of taking care of people. I find it hard to take breaks when I'm on shift because there are sick people all around me who need my attention. For you are working on like revitalizing this community and really modifying the way that we look at homelessness and coming up with a solution, essentially, and not a Band-Aid, which is all that we've had up to this point. It's a massive problem, right? So when it's your work and it's your focus, it can be hard to rationalize taking time away from it, because all you want to do is hammer away at the problem, right? But that's exactly how you burn yourself out. It's exactly how you exhaust yourself. A big thing in the healthcare community is the phrase compassion fatigue or compassion injury, which is when you exhaust your emotional stores so much that you start to lose the ability to care and provide compassion. And people in all walks of life are capable of experiencing this phenomenon. And the way that we prevent it from happening is that we replenish ourselves by doing things that we enjoy, and we disengage from the issue. It may be hard, like I said, to create that time. But if you don't take that 15-minute break, if you don't go get lunch with a friend or take a minute to read a book that makes you feel good instead of desperate and hopeless, then you are only ever going to feel desperate and hopeless. And you really have to craft spaces that are conducive to you doing that. You have to surround yourself with people who will validate you in doing that, rather than really putting yourself in a bind and sort of miring yourself in the problem. You need to maintain a healthy enough amount of distance that allows you to disengage and sort of recover yourself. And I think doing things that make you feel good is an important piece of that. So reading for me is wonderful, but I also, I love video games. Like I play a lot of video games when I'm stressed because it's nonsense and it helps me to forget about things that are very real and very problematic. And there's something comforting in the virtual when you feel like all you're doing is bemoaning reality.
I'm 100% with you. And for me, it's napping.
I love that.
I'm a huge nap fan.
I'd like to be as unconscious as possible.
I love it. I'm actually award-winning at it, so I'm a pretty competitive person. But when it comes to thank you. When it comes to napping, I'm the best at it. So I can nap anywhere for any length of time.
I love that.
In any setting. So that might be called narcolepsy, and I could probably get that checked out. But in any event,
sounds to me like a circus act.
Okay, I love it. Hey, we could take this on the road.
Yeah.
But I also, another element for self-care for me, which you mentioned, is like maybe having lunch or spending time with a friend. And I do consider you to be part of my self-care. And there have been times where we have gotten together and you've read my tarot cards and, we taught me how to bake bread and had days like that. And I think we need more days like that to cultivate and remember our friendships, the type of friends that are nourishing, because sometimes people can be exhausting and really consuming, and so it's important to spend time and have time with those relationships that kind of refill your cup.
Absolutely.
And I count you amongst those. So I'm grateful that
You're
I
among
have
mine.
that. So I also, in our remaining time, want to talk a little bit about solutions and really how other places are trying to problem solve some of these issues that we discussed in terms of patients who are low income and healthcare and the really problem of healthcare in the marketplace. But there's one thing I want to talk about in particular. The University of Illinois, as I mentioned, has this unconventional treatment for people who are homeless. Who are, if you're a homeless patient in at Chicago Hospital, you can be 70 times more likely to seek medical care, and your medical costs are 70 times higher than other patients who are not homeless. Not 17 times higher, 70 times higher if you're homeless, your medical costs are. So, and often that's because, as I mentioned, people who are low income and homeless, sometimes illness is what creates the homelessness or is part of the problem, creates a situation of economic poverty. But oftentimes it's the other way around. It's that homelessness and low income create medical conditions and put a strain on hospitals and especially ERs. So their medical costs are 70 times higher. And so the University of Illinois and said that what we're going to do is we are going to pay people's rent, because if they had stable housing, that is a form of healthcare, really.
Absolutely it is.
And so, and this is going to make the case that, obviously people need housing and this is the humane thing to do, but it is also the economically sustainable thing to do. We cannot continue in this system that we currently have with our healthcare costs so high,
Right.
To be caring for people in the ER. So if you care for people by housing them, it really does cut down on ER visits and medical bills.
Absolutely.
Yeah. So this hospital in Chicago has tried that, has taken people who are the biggest ER users, they're called super users, and instead has really financed their rent, which is what we need because there's a lack of affordable housing in this country. And
everywhere.
Yeah, absolutely. And we're certainly seeing that in Philadelphia. But to give people housing really cuts down on their hospital stays.
Absolutely.
So I think that this is really an ingenious thing that maybe is not, like I said, just humane, but cost effective.
I absolutely agree. I think it was an excellent pilot program, and I would love to see it implemented in Philly.
Me too. And so I think we need to start thinking out of the box because the problems that we have and the solutions that we've created, as you mentioned, are just Band-Aids. And we really need to understand this problem systemically and how we can create sustainable solutions that are not just Band-Aids, not just reforms to the system, but a new system completely overhauled that works better for all of us. Because when we care for people on the margins, it really is good for all society at large.
Absolutely.
And so these kind of pilot programs like this hospital in Chicago helping pay for rent to cut down on hospital costs, I think that's ingenious and maybe something that we can start here because what we really need is more housing for people. And that, as I said, is a form of healthcare.
Absolutely.
But thank you, Dylan. Our time is up, but this has been a great conversation. And I'm so grateful that you joined us today. You really taught me so much about Hahnemann Hospital and about nurses and patients and really how the closing has affected everybody throughout the city, and how we might work to advocate for people who are hurting the most.
Thank you so much for having me. It's been my pleasure. Okay. If I can offer any final thoughts, it's that just take care of your neighbors and keep an eye on them and get your flu shot, please. Oh my God, it's flu season.
Absolutely.
It's the single best thing you can do for public health.
Do it. That and an app. Okay.
Absolutely.
Thanks so much, Dylan. We'll see you next week on Thinking Constellationally.